All right, good morning, everyone. Thank you so much for joining us for part 2 of our spring survey series. We're glad that you could all be here, and we have got a great presenter today. We're really excited. Just some housekeeping. As a reminder, please make sure that you mute your phones. If you have any questions throughout the presentation, please put them in the chat box. I'll be monitoring that, and we will address them throughout the presentation as well as near the end of the presentation. With that, I'm very excited to introduce Janine. She is a registered nurse with over 30 years experience in long-term care, working in all nursing capacities from nursing assistant, charge nurse to MDS coordinator, staff development coordinator, ADON, and DON. She is also MDS certified through AANAC and is a certified legal nurse consultant. Her background includes serving as a corporate nurse consultant and the director of clinical services for a multi-facility, multi-level of care organization. Janine serves as a founding member of the Kentucky RUG Task Force Committee and has served on the Case Mix Appeals Panel and the IDR panel as a provider representative, as well as serving on the Kentucky Medical Technical Advisory Committee. She has extensive experience in the RAI process, clinical documentation, legal nurse consulting, restorative nursing programs, fall management, QAPI, infection control, and has provided training on these topics for state and national organizations. And her and I were chatting right before we started that survey keeps me up at night, and I have been so anxious just about the resumption of survey and what that means for our members and our providers. So we're really glad that you're here. Hope you gain a lot from this session. And with that, Janine, thank you for being here, and I will turn the time over to you.
Thank you very much. It's great to be here with all of you. Thank you so much for having me. Just say hello, and then I'll go ahead and get started into today's presentation. I really appreciate the opportunity to be with you. I know this is a source of nightmares for many people throughout the nation, not just in Utah.
At least I think I'm
we're going to discuss here what our objectives are for today. We're going to become familiar with the 2022 and current top cited state and national deficiency trends. We're going to recognize the top 10 cited deficiencies for Utah specifically, and we're going to identify some best practice recommendations to help prevent those top cited deficiencies. So let's get right into it. Let's first take a look at the survey trends going on, not only just in Utah, but throughout the nation as well. So as of when I put together the Q-Core information, the Q-Core data for calendar year 2022, you can see the trends here that, I'm sorry, can everybody hear me okay?
Yes, I'm sorry. I was just muting someone. Sorry about that. Continue.
Okay, that's okay. Okay, very good. All right, so for our deficiency count, we can see where each region, survey region, is ranking right now. Of course, each region is a little bit different in size, so that will account for a lot of the differences in the numbers. But you can see that for the year 2022 overall, that the Chicago region was in the lead with over 30,963 total deficiencies. We also see then in second place was the Dallas region, followed by the San Francisco region, and then the Atlanta region. And Kentucky, where I reside, happens to be in the Atlanta region. And unfortunately, Kentucky is one of the highest ranking when it comes to immediate jeopardies as well. And you can see that reflected in the numbers in the J, K, and L columns on this particular slide. You can see that the Atlanta region ranks very, very high when it comes to the immediate jeopardy deficiencies, and is followed by the Chicago region and then the Dallas region. So in overall deficiencies, you can see where the highest numbers total are and where the highest numbers of immediate jeopardies are found for the year 2022. And just so that you can see that in perspective, you can see here that the Atlanta region, as I mentioned to you, was the first overall when it came to total J, K, and L deficiencies or immediate jeopardy deficiencies or percentage of immediate jeopardy deficiencies, which is region 4. That was followed by the Chicago region, region 5 with 26%, then the Dallas region, region 6 with 19%, and the Kansas City region, which is region 7 at 8%. Now, Utah's region, the Denver region, which is region 8, was in 9th place with 61 J, K, and L deficiencies, with only the Seattle region, which is region 10, lower than the Denver region. So you're really not doing bad at all when it comes to immediate jeopardy deficiencies. You're ranked one of the lowest out of the 10 regions, with only Seattle, as I said, being a little bit lower than your particular region. Now, when it comes to the deficiencies that are being cited, again, let's look specifically more at your region, which is, as I said, Region 8, the Denver region. So for the state of Utah, you can see where you rank. I've got the red arrow there for you. You can see that in total number of deficiencies, you were second to Colorado, which led with 1,645 total deficiencies, whereas Utah was in second place with 865, followed by Montana at 671, and then North Dakota at 478, South Dakota at 332, and then Wyoming at 272. So in total number of deficiencies, you can see that you had second place with 865. But again, remember that the number of facilities in each region is going to vary, so the numbers will vary as well. Now, when it comes to the calendar year of 2023, so far in 2023, where do we look like we're at right now? So again, for the Denver region, your region, or Region 8, you can see that Colorado is currently in the lead with 296 total deficiencies, followed by Montana at 207, and then Utah in third place at 84, followed by South Dakota at 71, and then North Dakota at 57, and Wyoming at 43. So looks like calendar year 2023 thus far is following fairly close to what it was in 2022, but you have dropped down from second to the third level as far as total number of deficiencies. So far, you're in a three-way tie when it comes to having no immediate jeopardy deficiencies, no JK or L deficiencies. You're in a three-way tie with North Dakota and Wyoming, which is great, and hopefully you will stay there if at all possible. Now, another thing I think we need to make note of, and this is particularly important for some regions, is that there are so many, as you are well aware of, overdue recertification surveys. So when you look at going 18 months since the last survey for facilities, you can see that how each region is ranking here. And I will let you know, we're going to see a slide here shortly that shows you that Kentucky, the state that I reside in, unfortunately, is one of the top-ranked regions, top-ranked states with having the most overdue surveys. We are experiencing significant shortages in our surveyors. We're having a very difficult time getting surveys done. The survey groups that we have are trying to do primarily complaints and immediate jeopardy related issues, and we're just falling way behind when it comes to the annual surveys. Now in your region, again, Region 8, the Denver region, you can see that Utah is in
Looked in here so I get credit.
oh yeah, you can see Utah's in second place. I'm sorry, lost my train of thought there for a minute. You can see that Colorado's in first with 25.7% of facilities being 18 months or more out, followed by you and Utah at 23.5%. And then the other states that you can see are really in low percentages. Montana only at 4.6, North Dakota at 5.1, and North Dakota at 2.6, South Dakota at 5.1. So, and Montana at 4.6. So I'm not really sure what's going on other than perhaps the number of surveyors that are available. Again, the number of facilities needing surveys will affect that number as well. But as of right now, with the 18 months out, Utah is in second place. So you're unfortunately experiencing, as we are in Kentucky, a very high number of facilities awaiting survey for a very long time. Now, when we look at the 24-month period of time, you can see that, as I mentioned to you, in first place was Region 3 with the state of Maryland at 73.3%. Region 4, which is the region that I'm in Kentucky, the Atlanta region at 73.3%. And then Region 10, which is your Seattle region, Idaho at 70%. And this was as of about, just I think a couple weeks ago when I was putting this data together, and it really hasn't changed much the last few times that I've checked it. So for greater than 24 months, you can see that Utah is not even listed in the Denver region, Region 8, as having any facilities that are 24 months or more out from their last survey, which is, I find a little bit hard to believe. I'm not really sure why it's showing up that way, because it sounds like from the discussions I've had that you do have some that are that far out, but as of this Q-Core data, Utah did not show up as having any facilities that were overdue more than the 24-month mark. Now, when it comes to the actual deficiencies that are being cited, let's do a little bit of a comparison between 2022 and 2023. And looking at the top 10 deficiencies nationwide for all of calendar year 2022 as compared to so far in calendar year 2023, we see that the top 10 deficiencies are exactly the same in content. In other words, it's the same top 10, but F880, infection control, and 689, your accidents and supervision to prevent accidents, and also 812 and 684 have kind of changed places in 2023 thus far from where they were in 2022. But as you can see, overall, it's the same top 10, just a little bit different in the ranking of where those particular top 10 deficiencies are falling. Now, specifically for the state of Utah, when we're looking at, again, 2022 compared to 2023, we see differences not only in the top 10 deficiencies for calendar year 2022 as compared to the national top 10, but we also see that there's differences between 2022 calendar year deficiencies and those so far in calendar year 2023. So you're not following the national trends as closely as some other states and regions are, and you're seeing a difference between what the major deficiencies or the most deficiencies were in 2022 as compared to 2023. Now, when it comes to your ICF and IID facilities, you had a presentation that was done in your state by your Division of Licensing and Background Checks that did this back in April for you. And according to their data, from March 1st of 2022 through February 28th of 2023, for ICF and IID facilities, there were a number of relicensure facilities that had surveys completed. There were 14 of those, and there were 16 complaint surveys that were completed. And then total deficiencies cited amongst those surveys that we see there was 111. Now, also we see that for your assisted living facilities, from, again, March of 2022 through February of 2023, we see that the average number of deficiencies was 8, and CMS apparently requires a 12.9-month average between surveys with none over 15.9 months. But for some reason, your average time between surveys for assisted living is averaging about 11.88 months, which is falling below that 12.9-month average. And is not going over that 15.9-month requirement that your particular state has. Now, when it comes to surveys completed for assisted living, again, between March 1st and February 28th, we see relicensure surveys at 58, complaint surveys at 121, and initial surveys for assisted living at 4. We have a total number of deficiencies overall of 1,616. Class 1s were 27, Class 2s at 1589, and there were CMPs issued in 69 of those circumstances for those deficiencies that were cited in that time frame. Now, for your assisted living facilities, again, average deficiencies per survey was 9. Facilities with between 20 to 35 deficiencies, there were 26 of those, and the average time between surveys was 31.07 months. From survey to survey. So we can see that your assisted living facilities and your ICF, IID facilities are in the same boat as the rest of us, that they're running behind in completing those annual reviews. So let's take a look at the Utah survey data top 10 deficiencies based on what the survey agency presented in April to your state. So the top 10, and I'm going by data from October 1st of 22 through April 7th of 2023. And so that information is going to be a little bit different than what we saw in those slides from the period of time that your survey agency was using. So at number 10, we have F758, which is that facilities must be free from unnecessary psychotropic medications, and you have certain requirements for PRN use of those medications as well. At number 9, we have F684, which is the quality of care tag. Number 8 is 677, which is ADL care that's provided for our dependent residents. 584 is number 7, That's your safe, clean, comfortable, and home-like environment. Number 6 is 578, which is where residents can request, refuse, or discontinue treatments, and they can have the right to formulate advanced directives. Number 5, we see 656, which is to develop and implement the comprehensive care plan. At number 4, we have 880, which is the infection control and prevention tag. Number 3 we see is 812. This is almost always in the top 10. I can't recall how many years back it's been in the top 10, but 812 is your food procurement, storage, preparation, and serving food under sanitary conditions. Number 2 is 757, which is the drug regimen review, and that any irregularities must be reported and acted upon. And then we have at number 1, F689, which is free of accident hazards and then supervision and devices to prevent those accidents. And while it wasn't in the top 10, I've also included in today's presentation F600, which is free from abuse and neglect. And that is because in the presentation that was done for your state by your state survey agency, they indicated that there's been a significant rise in not only the number of abuse-related deficiencies that are being cited, but also the scope and severity, the significance of the abuse that is being cited within your state. So I put that in there as well, and that was not only at the SNF level, but also at the ICS, IID level and assisted living level as well. So it affected all levels of care. So the first thing we want to talk about is knowing your survey information and where you can find it. And I've given you on this particular slide the direct link that will take you to the CMS website, where you can go under the downloads at the bottom of the page, and you'll find all of these wonderful survey resources that are posted by CMS. So your Appendix TP, your State Operations Manual, the watermelon book, as most people call it, you'll see a blue arrow pointing to that, where that is located on this list. You'll also see a blue arrow just above that for the long-term care survey pathways, the CMS critical element pathways. If you're not familiar with those, you really need to become familiar with those. I'm going to show you examples of those today, but those are probably some of the best tools that you can incorporate into your QAPI process and use for auditing purposes to help you make sure that you've got everything in place that surveyors will be looking for when they come into your facilities. That is what surveyors will be using when they're doing your survey process. That is the information that is built into their software, in their laptops that they're using to conduct your survey. It has all the questions that they'll be asking and reviewing and looking at when they do interviews or when they're doing observations or whatever it is that they're reviewing. So we have access to those tools as well, and we should take advantage of that. So I've pointed out to you those specific survey resources, but you can see that there's a list of all kinds of other resources here. Your entrance conference forms are here. Your 672-802 forms are here for you, the ones that must be filled out and given to surveyors when they arrive. Immediate jeopardy templates are on here. So all kinds of excellent information. Definitely a website you should be very familiar with and be checking frequently, because they do update this on a regular basis. So let's start now with our top deficiencies. Let's start with F758, which was free from unnecessary psychotropic meds and the PRN use of those. First thing we're going to do is we're going to look at some actual deficiency examples that occurred within your state. And these were also reported in that same training that was done by your state survey agency back in April. And they reported that these deficiencies, there were 6 total that were cited under this tag, and that 5 of those were at the D scope and severity level, and 1 was at the E, which is the pattern level, D being the isolated and E being the pattern level. So in the first example, we see that a resident had been on an antipsychotic medication for 7 months without any documented indication for use. And as we know, we've got to have a specific indication for the use of that category of medications, whether it be diagnoses or symptoms that the resident is presenting or whatever that might be. In the next example, we have that review for a GDR, or gradual dose reduction, was not performed on a resident on an antipsychotic until after the survey had occurred. But the review was indicated prior to the time of the survey. In other words, the resident had been on that medication for quite some time and should have been reviewed prior to the survey occurring. In the next example, we see a resident was receiving multiple psychoactive medications that were not considered for dose reduction despite a lack of target behavior. So in looking at the documented behaviors for that resident, there wasn't a lot of the target behaviors being demonstrated by the resident that warranted or justified the continued use of those medications, and it was not being reviewed for possible GDR by that facility. And in the next example, we see that there was an order for Haldol PRN for a resident that had an indefinite end date. Now, we know that the regulations state that you can do that. You can have prolonged periods of time beyond the 14 days that are limited for PRN use, as long as you have documented information from either your physician or physician extender as to why it is needed for beyond that initial 14 days. Indefinite is really not appropriate unless you've got very specific indications of why it would need to be used indefinitely, such as you might see perhaps with an end-of-life patient that might be on hospice or something like that, in which case with hospice, the anticipation would be, of course, that there would be a period of time that it would be used that would be not indefinitely. So let's look now at the specific requirements, the regulatory requirements under F758. So under regulatory grouping 483.45, section C3, we see that the regulations state a psychotropic drug is any drug that affects brain activity associated with mental processes and behavior. These drugs include, but are not limited to, drugs that are in the following categories, and that includes, of course, your antipsychotics, your antidepressants, your anti-anxieties, and your hypnotics or sleeper medications. Now, we also see that based on the comprehensive assessment of a resident, the facility must ensure that residents who have not used psychotropic drugs are not given that classification of drugs unless the medication is absolutely necessary to treat a specific condition that is diagnosed and documented specifically in the resident's clinical record. And that's where we saw those deficiency examples that had occurred within your state where there wasn't the documentation to justify and support that specific condition or diagnosis that warranted the use of that category of medication. Now, we continue to see that in the requirements that residents who use psychotropic drugs must receive gradual dose reductions and behavioral interventions unless they are clinically contraindicated. And that would require, again, specific documentation to show why it is clinically contraindicated for that particular resident. And typically this is because the resident's symptoms will return or could come back more exacerbated than they were originally. Perhaps the residents reached a very stable therapeutic level that might be disrupted if you should do a GDR. Those would be examples of clinical contraindications, but whatever the contraindication is, it must be documented in the resident's clinical record to show why it is specifically clinically contraindicated. So in other words, we must make an effort to discontinue these drugs unless we have that documentation to support that clinical contraindication. Now, also we see that residents do not receive psychotropic drugs pursuant to a PRN order unless that medication, again, is necessary to treat a diagnosed specific condition that is, again, documented in the clinical record. So if you're going to have PRN meds, there's got to be justification for the use of them on a PRN basis. Next, we see that PRN orders for psychotropic medications are limited to that 14 days, as I said earlier. So unless the attending physician or the prescribing practitioner, the physician extender, believes that it's appropriate for that PRN order to be extended beyond that 14 days, okay, if they do, then they should document their rationale in that resident's record that indicates what the duration of the PRN order should be. In other words, indefinite really isn't appropriate. It should be limited to a certain time frame and then reevaluated at the end of that time frame. And then finally, we see that PRN orders for antipsychotic meds are limited to 14 days, and those cannot be renewed unless the attending physician or extender evaluates the resident for the appropriateness of that medication. So in the case of that Haldol, which is that antipsychotic medication, you really can't have that indefinite use. That PRN is limited to that 14 days and cannot be renewed until it is reviewed by that physician or extender and then documented as to that it is appropriate to go beyond that 14 days. Now, the intent of this requirement, of course, is to make sure that each resident's entire drug and medication regimen is managed and monitored to promote or maintain their highest practical mental, physical, and psychosocial well-being, as with everything that we do for our residents. The facility must make sure that they implement gradual dose reductions or GDRs and non-pharmacological interventions. In other words, we must show that we're trying to do things other than just the medication, unless, again, it's contraindicated, prior to initiating or instead of continuing psychotropic meds. So we've got to show those efforts of using interventions that are not just medications. And then again, the intent is to make sure that PRN orders for psychotropic meds are only used when the medication is necessary, and PRN use is limited to only those cases when it's absolutely necessary. Excuse me. So let's look at some best practices related to this F-tag, F758. First of all, make sure that all your medication orders address indications for use. And that is becoming even more critical because you've seen the draft of the, please excuse me, I've got a tickle today. You've seen the draft of the RAI manual, which is coming out October 1st of this year. The draft is out and is expected to be finalized sometime in August, according to CMS. And the item sets, the actual MDS questions, are out in final form. But they also are going to have on the MDS now that all of your medications must have a specific indication for use. So we should start getting used to that now if you're not already. So all med orders, not just your psychotropics, but especially the psychotropics, must have included with the order the indications for why it is needed and why it's being utilized. And that can be specific diagnoses, or it can be the specific signs and symptoms that are the residents demonstrating that are causing them distress and cause the need for the use of psychotropic medication. Another recommendation is that your behavior monitoring and tracking, that you've got policies and procedures for that in place, and that you make sure that your staff are doing that tracking in accordance with those policies and procedures. In other words, we want to know that we're justifying the continued use of medications, especially psychotropics, by showing what the residents' behaviors are doing. So when you have a period of time, as we saw in the deficiency example, where the resident's not demonstrating those target behaviors, we should be thinking right away of perhaps doing a GDR, again, unless we've got documentation to support that it's contraindicated. And then also a best practice, make sure that your PRNs are always limited, your psychotropic PRNs are always limited to 14 days, again, unless your MD or your physician extender has documentation of the rationale and the duration of how long they want that PRN to be used, and indefinite really should not be a choice for that. Now, I mentioned to you earlier the critical element pathways. I have an example for you here of CMS critical element pathway number 20082. This particular pathway has 9 pages to it. And as you can see here, it's going to walk the surveyors as well as us, because we have access to this as well. It's going to walk us through what we should be looking at in auditing our psychotropic medication use practices. So this is the one specific for unnecessary meds, psychotropic meds, and a medication regimen review. As you can see on this particular page, it's stating to review in advance of their observations. In other words, excuse me, surveyors are supposed to look at the information that you see here before they actually come out and interview and look at the records and those types of things. So they're going to be looking at the documents specific to the clinical indication for the use of that medication for that resident. They're going to look and see what your protocols are for antibiotic use, so your antibiotic stewardship programs. They're going to be looking for that you're demonstrating that each medication has an appropriate indication for use, as I said, and we want to get in the practice of having that included with our orders. Now, when it comes specifically to the use of antipsychotics, we can see on page 2 of the critical element pathway, these specific areas are arrowed for you with the big blue arrows. So we've got to show that we've got documentation of the duration for each medication that we use. We want to show that we've got documents of the clinical rationale for the continued use for medications, and that we're doing tapering or GDRs when they're appropriate. We also want to show that we've got a system for, and that we're documenting those GDRs for those psychotropics and for, and that we're using those non-pharmacological approaches, unless again that they're clinically contraindicated, and that we're also demonstrating adherence to the requirements for those PRN psychotropic and antipsychotic medications, that limit of 14 days. And then for the antipsychotics, it's renewed by the physician after the 14 days if they feel that's indicated, and then they must justify that in their documentation. Or we can extend the other psychotropic medications beyond that 14 days, again, with justification of the rationale from that physician or physician extended. Now, when it comes to medication-related top deficiencies for your ICF and your IID facilities, what was presented in April by your survey agency was that W368 had actually 3 citations as one of the top citations for your ICF and IID facilities. And that W368 is that all drugs are administered in compliance with physician's orders. So in this case, there were citations specific to the fact that medications were not being administered in accordance with what the physician's order specifically stated. Also, we saw that there were 2 citations for W369, which is the one that pertains to all drugs, including those that are self-administered, are administered without air. And that is something quite significant to think about when, if you determine that a resident is able to give their own medications, it is still the facility's obligation to make sure that they're able to do so without air, and that they're taking those in accordance with the physician orders again. So that is something that really needs to be focused on, as it is one of the top cited deficiencies according to your state survey agency. Now, some best practices for 368 and 369. I would highly recommend staff competency testing for medication administration, if indeed you have staff administering those medications, and that there be some type of testing that is done upon hire and at least at a minimum on a yearly basis. So staff competency testing for accuracy with medication administration upon hire, and at least yearly with yearly competency testing, and then do some random medication administration observations, perhaps on a quarterly basis, so that you just go out, choose a staff member that might be administering meds, and observe them and make sure, maybe use a checkoff sheet, or use the actual critical element pathway, the survey critical element pathway that they use for observing medication administration, and conduct your testing that way. Also, I would highly recommend, if you don't have it, that you have an assessment for the resident's ability to self-administer meds. You can't determine that a resident can do so safely unless you've assessed them for the ability to do so. There are examples of that. Your 2 major forms organizations, your MedPass and your Briggs Corporation, those are the big form companies, have sample resident self-administration of medication assessments that you could refer to, or you can develop your own, or you can do a search and see what other is available out there for you. But I highly recommend, if you've not done so, that any residents that you're going to allow to keep any medications at the bedside or to self-administer, including inhalers that you might be standing there and supervising, but they might give themselves, you want to make sure that you've conducted and completed a self-assessment assessment for them to make sure that they're safe to do that self-administration of that medication without air. And that's something that, as residents' cognitive abilities will sometimes decline over time, you would want to determine how frequently that would need to be done to make sure that you're catching any changes in that resident's cognitive status. Let's look now at the next deficiency, and that's F684, which is our quality of care tag. I'm going to stop just real briefly and make sure that we don't have any questions for the tag that we've just covered. Allie, can you let me know, do we have any questions related to what we've just covered so far?
I do not see any at this time.
Okay, excellent. Thank you so much. Let's move on with F684, which is our quality of care tag. Again, let's start by looking at some of the examples that your state survey agency provided in the training that they did. According to their information, again, you had 6 deficiencies cited under this particular tag. 2 of those were cited at the G, actual harm level. 1 was at the E level, and 3 were at the D, scope and severity level. And the examples include inconsistent monitoring of neurochecks after residents were found on the floor that had injuries to their head, and that's quite significant. You should always have a policy addressing the frequency of your neurochecks when a resident does indeed have an injury to the head, or I even recommend having a policy if the resident is found on the floor and we have not been able to verify if it involved a fall that included hitting the head. So if you don't know for sure, the resident isn't a reliable historian to tell you, you should always have neurochecks as part of that protocol. Also, we had an example where the facility did not coordinate with an orthopedic surgeon for scheduled follow-up appointments was cited here. We see that treatment of skin infections was not added to the treatment record and was not present when they observed during the survey process, so the treatments were not being done. Resident complaints of rash were not addressed. Resident had scratched their skin until it bled and it had not been addressed by the facility. There was a 13-day delay from the date of a new wound from it being identified to where the treatment was actually initiated. So that's a pretty significant delay, and the wound could have progressed quite significantly during that time. A resident was admitted with 2 sets of admission orders. Order clarification was not completed, and that resulted in medications not being administered, some wrong medications being administered, and some missed lab tests that were needed. And then we also see an example where a resident with a severe rash was not receiving the prescribed treatment. So there were 2 examples there of some rashes where residents weren't getting the necessary treatment. So let's look at the requirements for F684, which is our quality of care F-tag under 483.25. We see that quality of care is a fundamental principle that applies to all treatment and care provided to our residents. Based on the comprehensive assessment of a resident, the facility must ensure that the residents receive treatment and care in accordance with professional standards of practice, their comprehensive person-centered care plan, and their resident choices, including but not limited to the following areas that are outlined. And we're going to take a look at these throughout this information. So the intent, again, of this requirement is to make sure that facilities are identifying and providing the needed care and services that are resident-centered, in other words, putting the resident at the center of everything that we do, and that they're in accordance with the resident's preferences, their goals for care, and professional standards of practice, and that they meet each resident's physical, mental, and psychosocial needs. So under this requirement, the things that are cited here are, it's kind of, I refer to it as a kitchen sink tag, if you will. Issues that don't really fit into any of the other F tags are often put here under 684 quality of care. We also find that your non-pressure related wounds, such as arterial wounds, diabetic wounds, venous wounds, that's why we saw the skin issues that were cited here, the rashes, the skin issue that didn't have the treatment. They're cited here because it's wounds other than pressure wounds that fall under the quality of care tag 684. We also find under this tag that your hospice and your end of life care it is under this 684 tag, and that's because they want to make sure there's good coordination of care between the hospice and the facility. In other words, things don't fall through the cracks because the facility thought hospice was going to provide it, hospice thought the facility would provide it, and then it just doesn't happen, and the resident might suffer because of it. So these are the requirements that fall under this tag specifically. So let's take a look at some facility best practices for the quality of care tag. Hopefully you're very familiar with the Interact program. The Interact program was a program designed through a quality assurance program that was, I believe, initiated in the state of Georgia. It has some wonderful, wonderful tools. They are totally free of charge. Some are actually built into some facility computer software. Some computer software has built-in Interact forms and programs into the software so that when, for example, one of the forms they have is something known as an SBAR, which is a form that you can use when there's been a resident change in condition to assess that condition and communicate it to your physician. And some software has built the SBAR tool into their software so that it is something that your staff can choose from and utilize when a resident change in condition has occurred. So the Interact program has tools that help you to assess for and document resident changes in status. It also has a wonderful portion that is pertaining to resident advance directives and how you can communicate and educate residents and families on advance directives, some really excellent, excellent tools in there. You also want to make sure that you have a very good NeuroCheck policy in place, as I mentioned to you. Not only should your NeuroChecks be done for, I would say, a minimum of 48 to 72 hours after a known head injury has occurred, but also should be in place if a resident has had a fall and you're just not able to determine for sure that they've hit their head. you want to err on the side of caution and do those neuro checks as well. You want to make sure that you're doing weekly wound assessments for all wounds. That includes measurements if it's something that can be measured. Now, I know that primarily facilities will usually measure and stage pressure-related wounds, and yes, we absolutely should, and that falls under the pressure wound-related tag. But for any other wounds that would fall under this category or under this F tag, under 684, and that would include, of course, your diabetic wounds, your venous or arterial wounds, I still recommend, if at all possible, that you provide measurements for that. It gives you a good way of demonstrating the progress, the healing progress of any wounds that you have. I even go so far as to measure bruises, skin tears when I can, any type of wound. I like to measure so that I can show week to week, is that wound showing healing progress? And if not, then I know it's time to change my treatments and get orders that will change the treatment because it's not making progress. Or if it shows evidence of immediate decline, then I would get new order changes as well. And then another good practice is to make sure that you've got 2 nurses reviewing your admission orders, because we saw that example in your state where orders weren't, there were 2 sets of orders, they weren't put in place, there was errors because of it. Not a bad idea to have 2 nurses to review admission orders and then review all of your new admission residents within 24 to 48 hours of admission, not just the orders, you should do that immediately, but take a look through the new admission paperwork within 24 to 48 hours of that admission to make sure everything's in place, to make sure that follow-up was done if it was necessary. For example, let's say that there was lab work that was done at the hospital that wasn't completed at the time of the resident's discharge, for example, a culture and sensitivity report. And I've unfortunately seen deficiencies because of this, where the facility didn't get the report from the hospital didn't automatically send it after the resident's discharge, and the facility forgot to follow up on it. And it turns out that it showed there was a very significant infection. So you want to make sure that you're looking at that documentation, so you're making sure that all necessary follow-up is done, that any labs that need to be obtained, any follow-up labs that need to be ordered, anything that needs to be done in addition to what you got on that initial admission can be followed up on. So those would be recommended best practices for this 684 tag. And also, I want to share with you again, there's a critical element pathway from CMS specific to hospice and end-of-life care. So it's another great tool that you can use if you've got residents that are receiving that type of care in your facility. And it's number 20073. This particular one has 5 pages to it. And again, it's going to walk you through what the surveyors are going to review and the observations that they're going to do and the interviews that they're going to do, both with the resident's family or representative, and the staff. So an excellent tool that you can use as part of your QAPI audit process. Let's go on to 677, which is our next tag, and that's the ADL care provided for dependent residents. And then after we complete this tag, I'll check and see if there's any questions on these 2 tags as well. So 677 is ADL care provided specifically for dependent residents. Again, your survey agency shared that there were 6 deficiencies in this particular tag. One of those was cited at the actual harm level at a G, and there were 5 at the D level, which is the not actual harm, but the potential for more than minimal harm, and the D being the isolated level. Examples that we see here of the deficiencies included a lack of toenail care provided for one resident that was dependent and could not do that themselves. A resident with significant weight loss and that had orders for max assist with eating did not receive that assistance when observed by the surveyors. An incontinent and dependent resident with perineal skin breakdown was not consistently having brief changes and incontinence care as was needed to address that skin breakdown. Another example, a resident requiring extensive assistance had not been showered since her admission, which was 5 days earlier. And then finally, we see an example where a resident with extensive assistance needed for eating did not receive the assistance beyond setup assistance for multiple meals that were observed by the surveyors during the survey process. So you can see that feeding assistance is very frequently something that's cited. And if the resident experiences weight loss, as we see in that second bullet point, and this resident had significant weight loss, that is more than likely going to be cited at an actual harm level. So you want to make sure that that ADL assistance is being provided as that resident's needs have been assessed. So let's look at the 677 requirements. Again, under 43.24, we see that a resident who is unable to carry out activities of daily living receives the necessary services to maintain good nutrition, grooming, and personal and oral hygiene. So all of your ADLs would fall under this requirement, making sure that those residents that are dependent upon the staff for assistance with those ADLs are receiving that necessary assistance in accordance with their assessment. So in the surveyor guidance for this tag, it specifically says to the surveyors, look at these issues, ask these questions. Are staff providing ADL assistance in accordance with professional standards of care, in accordance with the resident's care plan and the resident's choices? Is the level of assistance that's identified as needed by the resident on the assessments and the MDS, is that matching the resident's care plan? So these are all things that we need to be looking at. Are the appropriate assistive devices in place and consistently being utilized when needed? And that can be anything from walkers and canes to wheelchairs to built-up utensils for eating, whatever it might be. We want to make sure that all assistive devices are indeed in place, in good working order, and available to that resident whenever needed. Is the resident being encouraged to do as much as they are able to do? We don't want residents to become dependent upon us if they're able to do some of that activity themselves. But we've got to be able to recognize when that assistance is needed and provide that as it's needed. So we want to encourage residents and allow them to do as much as they can for themselves. And this gets, I know, very challenging because staff are busy. They have a lot of things to do in a day, a lot of residents to assist. So it takes extreme patience to be able to allow that resident that extra time to do that activity if they can do so. But we don't want them to lose that ability. And then also staff, surveyors are going to look to see if staff are explaining care before they actually provide it. And that, again, as I said, they're being patient. They're not rushing the resident. They're telling them what they're going to do before they do it so that the resident's not startled. And also, residents with dementia, if they're not explained what's going to happen, they can be frightened by it. And that would be a situation that might preclude them to being more resistant to the care, refusing the care, or becoming combative with care. And so one way that we can prevent that from occurring is by making sure that we're explaining to the resident what we're doing before we do it. So again, we've got the CMS critical element pathway, number 20066. This is specific to activities of daily living. You can see where I've got the blue arrow down on the left-hand side of the slide, that the surveyors are going to be doing observations across all shifts. So they're going to be looking for the provision of ADLs, which includes teeth clean, hair clean, brushed. Are their nails clean and trimmed? Is there evidence they've been bathed? Is the care being provided based on their preferences, whether it's shaving for a female or a male? Do they want chin hair or facial hair removed? Is appropriate hygiene, including toileting and continence care, being provided? And is the resident being dressed in accordance with their preferences? On the right-hand side, you can see that they're going to look for a resident who's not able to carry out ADLs. Are they getting that assistance that they need with those ADLs? Are they being encouraged to do as much as they can and then being provided that follow-up assistance as it is needed? So again, this critical element pathway, which has 7 pages to it, will walk you through all the things the surveyors will be looking at when it comes to the ADL. Okay, Allie, once again, can you tell me, do we have any questions on these 2 tags that we've just covered?
No, ma'am.
Okay, thank you so much. Let's move on to F584, which is a safe, clean, comfortable, and home-like environment. Another frequently cited tag nationwide, not just in your own state. In this case, we did have, again, 6 deficiencies cited in this area, and they were all at the E level, which is the not actual harm, more than the potential for more than minimal harm, and at the patterned level at an E. In this case, we had examples where the soiled wheelchair cushions had urine odor. There were multiple wheelchairs that were dirty. A resident dresser had 3 of 6 handles broken off and therefore making the dresser, of course, dangerous for the resident to use. There was a dirty sit-to-stand lift. In another example, there was a plastic drop cloth in the area of a leaking ceiling in a resident room. The resident was actually in the room when this was occurring. There were damaged walls. General cleanliness with resident complaints about housekeeping not cleaning the rooms. So whenever there are resident complaints, you know that the surveyors are going to look at that, and that's something you want to be aware of from your resident council meetings. What kinds of concerns are the residents expressing so that you can look into those before a surveyor would. Other examples were broken furniture, dirty wheelchairs and care equipment, large carpet stains throughout the facility, couches in the common areas that were worn with holes. A resident room was dirty, the floors were in disrepair, there were broken blinds, soiled recliners as well. And then there was a continuous high-pitch alarm in a dining room that was noted, and the paint was peeling from the walls in some resident rooms. So those were the specific examples cited by your survey agency. Now let's look again at the requirements specific to F584. When it comes to safe environment, the resident has the right to a safe, clean, comfortable, and home-like environment, including but not limited to receiving treatment and supports for daily living safely. The facility must provide a safe, clean, and comfortable and home-like environment, allowing the resident to use their personal belongings to the extent that they're able to do so. This includes ensuring that the resident can receive care and services safely, and that the physical layout of the facility maximizes their independence and does not pose a safety risk. Also, that the facility shall exercise reasonable care for the protection of the resident property from loss and theft. Additional requirements is that the environment must be orderly and have a comfortable interior, that there must be clean bed and bath linens that are in good condition, that private closet space is available in each resident room, that there's adequate and comfortable lighting levels in all areas of the facility, that comfortable and safe temperature levels are maintained within the facility, as of facilities certified after October 1st of 1990, the facility must maintain a temperature range of 71 to 81 degrees Fahrenheit, so it must be within that range, and that the facility must maintain comfortable sound levels. There shouldn't be excess noise or real loud noise like that high-pitched alarm that the surveyors noticed that was continuously going off. Now, in this tag as well, we see that there's specific survey guidance that we want to be aware of. The surveyors are told to ask the following questions. Does the resident have any concerns with lighting, noise, temperature, or anything else that may affect their comfort? Are resident care areas and equipment kept clean and in good repair? Does the resident's room appear cluttered and disorderly with a lack of storage for clothing, belongings, or personal care equipment, which is often the case for buildings that are older and maybe have smaller resident rooms and maybe very small closets? Are areas of the facility used by residents designed or organized to ensure the resident can receive care and services safely without the risk of falling or injury while maximizing, again, the resident's independence? Do window treatments, bed linens, towels, privacy curtains, etc., do they appear clean and in good condition? Nothing looks worse than having bed linens with old stains that haven't come out or towels that are torn and worn in appearance. And how does the facility staff ensure that resident personal property is kept safe from loss or theft? Now, we also saw that there were some assisted living facility deficiencies that were related to the environment that were presented by your state survey agency. And you can see there were quite a few of those. There were 49 citations within that time frame that they said they were reporting survey data from. And the 49 citations were that the facility shall, related to the practice of the facility shall conduct maintenance, including preventive maintenance, to ensure that the facility is safe, clean, operable, and in good repair. So just like the SNF tags, we see that the environment must be maintained in good appearance, in good repair, with good maintenance, so that it's safe for residents to live in and to maneuver in without any risk of injury or harm. So while I understand that assisted living and ICF and IID facilities have a different level of care, that your regulations vary just a little bit, I still feel that it is in your best interest to look at and perhaps utilize some of the CMS critical element pathways. So this particular one for environmental observations, which is pathway 20061, it has 4 pages to it. And whether you're SNF or assisted living or ICF IID, I think it's a great tool. I would recommend that you use that link that I shared with you and download this tool, which will walk you through all the things that the surveyor is going to look at. So they're going to look at your call system. They're going to look at, are you accommodating resident needs? Are the temperature levels okay? The lighting levels? Is it a home-like environment? Is there a lack of hot water or is it too hot? On the next page, we see It's going to look at building, the building and the equipment is in good condition, and it tells you specifically what things they're going to look at. Are all areas and equipment in good repair as well? So regardless of your level of care, I think this is a great tool to use. Some facilities have developed their own checklists that they might use to do environmental observations. Whatever works for you is great. Our next tag is F578, which is the resident's right to request, refuse, or discontinue treatment and to formulate advance directives. So again, within your state, the state survey agency presented the examples of 6 deficiencies at a scope and severity of a D, which is the no actual harm, and it was isolated. The first example, the facility did not ensure that the POLST or POLST was completed as the resident wanted a DNR status, so it did not reflect what the resident's wishes were. The facility electronic health records and the POLST were contradictory. So what the resident's record stated was different than what the actual POST form represented in the documentation, which is very dangerous to that resident. In the next example, there was no record of a resident's advance directive. And the last one, the facility electronic health records again. So there was another example where they were contradictory. One said one thing and one said another. So you've got to be very cautious that everything matches, that everything's updated at the same time if there are any changes made, so that it will be followed through in accordance with the resident's wishes. So let's look next at our requirements under 578. Under 483.10, we see the resident has the right to request, refuse, and or discontinue treatment, to participate in or refuse to participate in experimental research, and to formulate an advance directive. There is nothing in this paragraph that should be construed as the right of the resident to receive the provision of medical treatment or medical services that are deemed medically unnecessary or inappropriate. So in other words, any care that we provide for the resident must be deemed medically necessary and medically appropriate. We cannot make the resident do things that are not considered to be medically necessary and medically appropriate. In addition, we see the requirements state that the facility must comply with the requirements that are specified in 42 CFR Part 489, Subpart 1, which pertains to the advance directives. So that's a separate tag, advance directives tag. These requirements include a provision to inform and provide written information to all adult residents concerning the right to accept or refuse medical or surgical treatment at the resident's option, and to formulate that advance directive. It also includes a written description of the facility's policies to implement advance directives and in accordance with the applicable state law. Facilities are permitted to contract with other entities to furnish this information, but are still legally responsible to make sure that the requirements of this section are met. So in other words, you might have other people that are helping the resident to do the advance directives or the POLST form or whatever it is, but the facility is still ultimately responsible. If an adult individual is incapacitated at the time of admission and is unable to receive information or articulate whether or not they have executed an advance directive, the facility may give advance directive information to the individual resident's representative in accordance with your state law. So whatever that hierarchy is of who takes responsibility for the resident when they no longer have that capacity, you would want to follow that requirement. And the facility is not relieved of its obligation to provide this information to the individual once they are able to receive such information. So if the resident comes in and they're not able to understand, but their cognition improves, then again, you are obligated to provide them with that information once they're able to receive and understand that information and have that capacity. So some best practices for this tag under 578, make sure you know your state statutes and regulations specific to the priority of who can make healthcare decisions for a resident when they lack decisional capacity. Your state might have most or POST forms. It might include living wills. They might have a healthcare surrogate designation, a DNR designation. There might be the withhold of artificial food or fluids, or the withhold of natural food and fluids, not just artificial food and fluids. So you need to be familiar with what your state requirements are pertaining to these types of healthcare decisions. Now, I did research and noted that in the state of Utah, you do have a POST form that is utilized within the state of Utah. So that is a form that you would want to be familiar with and make available to your residents if that is something they would like to pursue. And you would want to make sure that you're following the directions for healthcare providers that you see on the right-hand side of your screen that show how to use and fill out the POST form with your residents. So that's something you would definitely want to be familiar with and make sure that whoever is responsible for doing that with the residents understands how to do so. Let's move on to our next deficiency, which is 656, and that's developing and implementing the comprehensive care plan. Our deficiency examples, again, there were 6 deficiencies with 2 E's and 4 D's. In one, the care plan was not updated to address a wound that was caused by the Hoyer list. The resident care plan items were left blank. In another example, care plans were not addressing the use of the resident's supplemental oxygen. In another, the care plan was not updated following a resident's fall. In the next, we see care plan interventions for residents who smoke were not consistently implemented. So not only do we have to develop a good care plan, we've got to make sure those interventions are consistently implemented by the staff. Next, we see care plans did not address UTI, pain, or falls. In the next example, care plans were not developed to address the resident's ADLs. When ADLs were addressed, the interventions were not implemented. For another resident, the care plan did not address the respiratory function or their need for oxygen. And in the last, we see that the care plan did not address the resident's need for assistance with eating. So in this tag, we have the requirements of the facility must develop and implement, again, a comprehensive person-centered care plan for each resident that's consistent with the resident rights that were set forth in regulatory groupings 48310 and in section C2 and section C3. And that these must include measurable objectives and timeframes to meet the residents' medical, nursing, and mental and psychosocial needs that are identified in their comprehensive assessment. So in other words, what we've identified in the MDS as what the resident needs and what we've addressed on the care plan must indeed be put in place. So facility best practices related to this deficiency in 656, I recommend that your MDS nurses in some form or fashion, whether it be electronically or on paper, if you're still doing paper orders, that they get copies or notifications of all orders for all residents that they can use to update their care plans on a 3-time-a-week basis. Monday, Wednesday, Friday is what I usually recommend. That way your care plan stays current and stays with what's the most recent interventions for that resident, and you won't have a care plan that becomes stagnant and becomes outdated and doesn't match the resident's needs anymore. I also recommend that you consider assigning interventions to what I call primary problems. In other words, if you put a repeat intervention in multiple problems, let's say, for example, that you've got a resident where you're going to put in the ADL care plan the fact that they need perhaps a specialty mattress, a pressure relieving mattress. And then you go ahead and you put that same intervention in the skin care plan. And then you go ahead and you put it also in the resident's mobility care plan or whatever it might be. The more places you put it, the more likely it is you're going to forget to update one of those when something changes. So I recommend that your interventions that you want to repeat, put them in and assign them to one primary problem care plan. And then in all the other problems that you want to repeat that particular intervention, just put see also interventions in XYZ care plan so that it will refer them to that primary care plan. You only have to update it in the primary care plan. And then all the others where you've repeated it, you've just referred back to the one where it will always be updated, and therefore you won't forget to update somewhere. And that's commonly what happens when you have an outdated care plan or a failure to update, is that you forgot to get it in all the places where it was. I also recommend that you do care plan checks to make sure that the interventions are in place and are being consistently implemented. You can do this by a checklist. You can take the resident's care plan, or if you're using a Cardex or a CNA care plan record, take it out, look at the resident, check off, and make sure that everything that's on there is indeed in place and that it matches the resident's current needs. I also suggest that you combine like problems on the care plan together and address them all together, for example, such as psychosocial well-being, the resident's mood state, maybe behaviors, and maybe even psychotropic meds, because they all interrelate, and you're going to have interventions that are common to all of them. So rather than repeating them, you just put them all together in the same care plan. Make sure that you've got appropriate goals for each of those issues and interventions that address each of those issues. And then you don't have to have a 40 or 50-page care plan. So just another idea. Now, also we saw that there were some deficiencies cited at the ICF and IID and the assisted living level. And we're going to look at those. And these were, again, according to your survey agency. Under ICF and IID, tag W111 had 2 citations. And this is the requirement that the facility must develop and maintain a record-keeping system that includes a separate record for each resident or each client, and that the documents the client's healthcare, their active treatment, their social information, and protection of the client's rights. So in this case, they're just talking about that your record keeping must include information just as a care plan would in the SNF-NIF setting. So you've got to have documents that show that you've got all those things in place. Under W210, there were 3 citations, and this is a requirement that within 30 days after admission, the interdisciplinary team must perform an accurate assessment of the resident. So you've got to make sure that you are assessing and then developing that system of keeping track of those residents' needs. Under W226, there were also 2 citations. Within 30 days after admission, again, the team must prepare for each client an individual program plan known as an IPP. So within that same 30 days of that assessment, you've got to develop that plan based on that assessment. And then W249 had 2 citations. As soon as the team has formulated that client's IPP, each client must receive a continual active program consisting of needed interventions and services in sufficient number and frequency to support the achievement of the objectives that you've identified in that individual program plan. So in other words, just like with our care plan at the SNF-NIF level, the IPP must also be implemented and shown that it is indeed in place and being utilized for that particular client. Now at the assisted living level, there were actually 46 citations cited where the requirement wasn't met for a signed and dated resident assessment to be completed on each resident prior to admission and at least every 6 months thereafter. So again, similar type of deficiency. There's got to be an assessment completed for each resident with at the time of admission and every 6 months thereafter. So some facility best practices, whether we're looking at just the SNF-NIF level or the ICF, IID, and AL level. For ICF, IID, and AL, I recommend have a calendar where you keep track of resident assessments that are required at the AL level every 6 months so that you won't forget to get that done. Also, that assessment and the IIP that must be completed within 30 days at the ICF and IID level, make sure you're keeping that on a calendar so that you won't lose track of when that's due within that 30 days. People come and go. There's different staff members responsible for some of the same duties. So that's a good way to communicate on that calendar. So if you're not the one sole person responsible for that all the time, and somebody else is coming in, they will know where that date line is due. Also, I recommend doing those care plan or IPP checks to make sure those interventions that you've got addressed on that resident record are consistently being implemented. Now, our next tag is infection control, and that is F880. And we're going to look next at our actual deficiency examples from your state surveyors. In this case, we saw that there were 7 deficiencies. There was 1 at the S level, which is the widespread. There were 5 at the E level and 2 at the D level. Several examples here. I'm not going to read all of these to you, but just a few of them. The nurse did not change gloves after removing a dressing with moderate drainage and applying a clean dressing, so infection control issues there. Improper cough hygiene was observed. Facility was not following transmission-based precautions or TBP, which is so critical as we've seen with the pandemic, which has just ended. Putting a soiled brief back on over a clean dressing, Hoyer lift used in an isolation room, then in another room without disinfecting it, handling medications with your bare hands. So lots of examples here of infection control related issues. And surveyors are watching these like a hawk because of the pandemic that we've just been through and the infection control practices that became so very much to the forefront because of that pandemic. So in the requirements, of course, we must establish and maintain an infection prevention and control program designed to provide a safe, sanitary, and comfortable environment and to prevent the development and transmission of communicable diseases and infections. The infection prevention and control program must be established by the facility and has to include at a minimum the following elements. So there's got to be a system for preventing, identifying, reporting, and investigating and controlling infections and communicable diseases for our residents, staff, volunteers, visitors, and other individuals providing services, whether it be under contract or whatever the arrangement might be with the facility. And this has to be in accordance with your facility assessment and accepted national standards. In addition, additional requirements, whoops, sorry, I went a little too far. There has to be written standards, policies, and procedures for your program, which includes, but is not limited to, the following: a system of surveillance to identify possible communicable diseases or infections before they can spread to other persons in the facility, when and whom possible incidents of communicable disease or infection should be reported, your standard and transmission-based precautions that are to be followed to prevent the spread of infection, when and how isolation should be put into place, and this should include the type and duration of the isolation, depending upon the organism, of course, or the type of infection. A requirement that the isolation should be the least restrictive possible for the resident under the circumstances, and the circumstances under which the facility must prohibit employees with a communicable disease or infected skin lesion from having any direct contact with our residents, with their food, or if direct contact will transmit that disease, of course. And then the hand hygiene procedures that need to be followed by the staff that are involved in direct resident care. Additionally, the facility has to establish an infection prevention and control program designed to provide a safe, sanitary, and comfortable environment and to prevent that transmission, as we've said. And I'm sorry, I went backwards on that one. And a system for recording incidents identified under your IPCP program and the corrective actions that you're going to take if you find that there are incidents of breaches in infection control policies. You've got to have policies related to linen handling, how it's stored, how it's processed, and how it's transported to prevent infection. And there's got to be an annual review of your IPCP program, and it's got to be updated as necessary. And obviously the intent here is to make sure that your facility has a program in place that helps you to recognize, prevent, address, and control the onset and spread of infection to the extent that you possibly can, and to review updates annually as necessary. So, and this would of course change as infection control and prevention national standards change. We want to make sure we've got that facility-wide systems in place, that all of our policies and procedures are known to the staff, they've been educated on it, and that they are following it to the best of their abilities. We don't want to have those that are left behind. Facility best practices for infection control, effective screening for symptoms. Even though the pandemic is declared over, we are still required by CMS to have a quick response to symptoms. That includes testing if a resident or staff has symptoms and getting them in isolation or quarantine as quickly as possible if we have a suspicion that their symptoms are indicative of either COVID or another transmissible disease. Staff training should include the following: the correct type and the use of PPE with return demonstration to make sure they're doing it right, the type of isolation and quarantine that's in place, and making sure that they know how to do it correctly, management of your residents with dementia or that wander. How are you going to quarantine them? What are you going to do? Tracking and trending of infections. I recommend using a map of your facility and using a color-coded system to map your infections each month to help you identify trends and to help you track what those trends were and what you put in place to address those trends. And then you want to continuously review your process to monitor for compliance and do care observations to watch for any breaches in your infection control standards. Once again, there is a wonderful CMS critical element pathway, number 20054. It's got lots of pages to it. It's got 18 pages. And this was also revised recently, just to let you know. I don't think I put the most recent version in here because the new version came out after I had already put the slides together, but they updated this at the end of the pandemic. So just be aware that it's not major changes, but there are some changes in it because of the end of the pandemic. So make sure you get the most recent version, which is available in those survey resources that I shared with you. So as you can see, there are multiple pages to this, 18 pages. I've put the blue arrows highlighting those really critical areas: the hand hygiene, the correct use of the PPE, especially for standard precautions as well as transmission-based precautions. The use of gloves and appropriately doing so is so important, and observing staff to make sure that they're using appropriate infection control precautions between resident rooms, whether that be simple hand washing or hand hygiene, or the use of PPE if it's warranted. Now, the assisted living facilities had 50 citations that were related to infection control deficiencies, and those were under the requirement that all personnel shall be tested for TB within 2 weeks of hire. So this is an infection control related issue, and apparently the assisted living facilities were not making sure that all their personnel were getting that TB testing within 2 weeks of their hire date. So my recommended best practice for that is to make sure you give that TB test on the date of hire, and then make sure that you get that staff member back to read that test so that you have the proof of that result. Let's move on to F812, which is food handling, storage, and preparation. And again, this is a very commonly and highly cited deficiency area. There were 8 deficiencies under this tag at a scope and severity, 6 at an E and 2 at a D. Again, multiple examples. We'll just look at a few of them. The grill was dirty in the kitchen. The oil was cloudy that was in the fryer. Food was in the walk-in freezer and refrigerator, and the dry storage area that was just open to air and not packaged properly. A big one is uncooked meats that are stored above ready-to-eat foods that might drip down onto those foods. Uncooked bacon was stored above ready-to-eat foods. There were open beverages that were not dated. Not performing hand hygiene while distributing food, and hand hygiene when no hand hygiene going from dirty dishes to clean dishes. Hand hygiene, even in the kitchen, is a very, very big issue. And the biggest issue I see quite often is food items not labeled or dated, trash being left not taken care of appropriately, and foods not being correctly stored and used beyond their expiration or use by date in the refrigerator and the freezers. So the requirements of this tag under 43.60, the facility must procure food from sources approved or considered satisfactory by federal, state, or local authorities. This may include food items obtained directly from local producers, subject to applicable state and local laws or regulations. This does not mean that the facility cannot use produce that's grown in your own facility garden, as long as you follow the applicable safe growing and food handling practices. Also, it does not mean that residents cannot consume foods that were not provided by the facility. In other words, visitors can bring in foods, they can get them delivered, but it is still the facility's obligation to make sure that that food is safe for the resident to ingest. So we've got to make sure that we have policies in place about foods that are brought in from outside of the facility. Also under this regulation, the storage, preparation, and distribution and serving of the food must be done in accordance with professional standards for food service safety. So for facility best practices here, staff education obviously is the key. Education on food handling and food temps, education on hand hygiene, on kitchen cleaning schedules, on how to properly label and store food and make sure it's properly sealed and dated. I would recommend using the CMS critical element pathway, which I'm going to show you here next, to monitor your dietary sanitation issues. And here is critical element pathway number 20055. It's got 7 pages to it. And again, it walks you through all the things the surveyors are going to look at when it comes to dietary sanitation and kitchen practices. So wonderful tool to incorporate into your QAPI process. Let's look next, and I'm going to save the remaining questions for the end because I want to make sure I get through all of this information for you. So let's look at 757, which is the drug regimen is free from unnecessary drugs. In our examples, we had 8 deficiencies under this tag, 2 at an E and 6 at a D. Again, I won't read all the examples, but we had a nurse aide that administered a medication to a resident that the resident had in their own backpack and gave it to the resident without it being something necessarily ordered by the physician. A resident had been on a prophylactic antibiotic for nearly 2 years without any consideration about discontinuing it. Medication was held when parameters were not provided and the prescriber was not contacted. I see this a lot. They'll say, well, the resident's blood sugar was low and I felt that they might bottom out. Well, unless you've got parameters that tell you to do that, You're really not supposed to, or unless you notify the physician, should I hold this, you're really not supposed to hold it unless the orders specify otherwise. Blood pressure medications were administered when contraindicated based on the parameters. So in one case, we didn't have parameters to follow. And then the second case, we had parameters, but they weren't followed. So if you're going to have parameters, you got to make sure that the staff know to follow those consistently and what to do if the parameters are not met. Also under the requirements, we have your unnecessary drugs in general, that each resident's drug regimen must be free from unnecessary drugs. And it's considered unnecessary when it is used in either excessive dose, for an excessive duration, without adequate monitoring, without adequate indications for use, as we've already talked about, in the presence of adverse consequences, on which the indication for use should be reduced or discontinued, and any combination of the reasons that were stated in this particular regulation. So again, facility best practices, what can we do to avoid this tag? Routine medication administration observations is one of the best things you can do. And as I said, that critical element pathway, which I'm going to show you that the surveyors use when they're doing the medication observation, is a great way to do that. Routine medication storage observations, go in and audit your med rooms, make sure that everything's not expired and stored properly, and that you don't have nasal sprays in with oral medications or eye drops in with oral medications, et cetera. Use your critical element pathways that are related to medications, the unnecessary drug one that I showed you already, and the medication administration one, and the storage of medication one. Pharmacy services, have them come in and assist you with your QAPI process and do audits for you on a regular basis. And make sure that you're doing competency evaluations of your staff to make sure that they're competent to administer medications without errors. So here we have critical element pathway 20056, which is 5 pages long, and it is specific to the medication administration observation. And it shows you the list of all the things that the surveyors are going to be looking for. And I've given you arrows next to a couple examples. Medications were held and the physician was notified in the presence of an adverse effect, such as signs of bleeding or abnormal lab results with anticoagulants, and that they checked the pulse or blood pressure prior to administering meds when it's indicated and ordered. So this 5-page observation, critical element pathway, will also be of great benefit to you in self-auditing for avoiding this tag. Under 689, which is supervision and assistive devices to prevent accidents, we have the following examples. We had one at an immediate jeopardy level of a K, which is patterned. There were 3 G actual harm deficiencies, 2 E's, and 3 D's. In one example, the resident sustained a tear to the scrotum during a Hoyer transfer and required surgery. In another example, a resident fell from a shower chair as the CNA was pushing it and sustained a fracture to the tib fib. A resident in a wheelchair tipped over in the transport van while being transported from dialysis and sustained 2 small abrasions to the head. A resident's toes were run over by a shower chair, pulling 2 toenails off. And there were multiple residents that had recurring falls with no to few new interventions, and care staff were unaware that interventions were in place to prevent their falls. So lots and lots of examples. Don't forget supervised smoking. We've seen some very significant deficiencies cited for residents that have accidents during smoking. The requirements in this tag: the facility must ensure that the resident environment remains as free of accident hazards as possible, and that each resident receives adequate supervision and assistive devices to prevent accidents. And the intent, of course, is to make sure that the facility provides an environment that is free of hazards and that has policies and procedures in place to avoid accidents and to identify what are the hazards and risks to our residents, that we evaluate those hazards and risks, that we implement interventions to respond to those hazards and risks, and that we are monitoring for effectiveness and modifying any interventions when it becomes necessary. So some facility practices to avoid these kind of circumstances. Again, shower chairs are intended for showering, not for transporting residents. We shouldn't really be using them as wheelchairs. They tip very easily. They are not designed like a wheelchair, so it's very easy to run over resident toes. So it's best if you transport the resident to the shower and then transfer them from the wheelchair into the shower chair rather than moving them in the shower chair. You want to update your care plan in your fall management meetings. Do it right there while you're meeting on it to ensure that interventions are added timely to address resident falls. The longer you wait, the more the resident is likely to fall again before you can get an intervention in place. And then review those in safety huddles with your staff so that they know what the current interventions are for each of your residents. Also make sure that you have policies and procedures to address resident safe smoking and with interventions in place as indicated. And I would recommend a safe smoking assessment for all residents that smoke to help you identify those that might need things like safety aprons or whatever it might be. Now, in the assisted living level, there were some deficiencies cited for accident and safety related things as well. There were 8 citations in the requirement related to the facility not maintaining hot water delivered to the public and resident care areas that was between the required range of 105 to 120. And there were 60 citations where cleaning agents, bleaches, insecticides, or other poisonous or potentially hazardous materials weren't stored in locked areas. So these are important things to be alert to. Also, there were 47 citations where the facility didn't document all their drills, including the date, the participants, the problems that were encountered, and the ability of each resident to evacuate during a fire drill. There were 47 citations related to the name of the person in charge and the names and phone numbers of emergency medical personnel and agencies, and appropriate communications systems were not posted in prominent locations throughout the facility so that everybody knew how to access that if they needed it. And there were 42 citations where the facility did not hold simulated fire drills quarterly on each shift for staff and residents as it is required. There were also some best practices for assisted living related to these tags. In other words, monthly water temperature tests should be done, and that information should be logged so that you can prove that they were done. Safety inspections for proper storage of potentially hazardous materials should be done on a regular basis. You should use a calendar for making sure that your quarterly fire drills are completed and use a form to document those required drills so that you've got that information to prove it. And you should have posters in prominent locations in your facility with the required emergency information on it. Now, also, it wouldn't hurt to use the critical element pathway that is used by surveyors for accidents, the critical element pathway to review accident risks within the facility. You can see that I've got a blue arrow pointing to the smoking section of this particular critical element pathway, which is 20127, and it has 8 pages to it. I've also got an arrow here showing you the fall section. So again, it doesn't matter what level of care you are, could be SNF, could be ICS. This would also be a helpful tool to you as part of your QAPI process. Here is the section again related to interviews related to safe smoking, as well as interviews related to falls and entrapment or safety risks to the resident. Now, finally, I'm going to wrap up by looking at F600, which is abuse, neglect, misappropriation, exploitation, and involuntary seclusion. This was not one of your top related deficiencies. However, as I mentioned to you, your state survey agency indicated that there's an unfortunate upward trend in these citations, that they had been cited 18 times since March of 2022, with 6 being at the immediate jeopardy level of a J or a K, 1 at an H, which is an actual harm level patterned, 6 at a G, which is actual harm isolated, and 5 at the D or E levels, which is not actual harm. The findings included staff to resident types of abuse. There were numerous resident to resident sexual abuse allegations and numerous resident to resident physical abuse allegations as well. So the requirements in this tag are that under 483.12, the resident has the right to be free from abuse, neglect, and exploitation, as well as misappropriation of their property, and includes but is not limited to freedom from corporal punishment, involuntary seclusion, and any physical or chemical restraint not required to treat their medical symptoms. The facility must not use verbal, mental, sexual, or physical abuse, corporal punishment, or involuntary seclusion. So the intent, of course, is to make sure that each resident has the right to be free from abuse, neglect, or corporal punishment of any type by anyone. Here we see the definition of abuse. It's defined in the tag in the Appendix PP. It's the willful infliction of injury, unreasonable confinement, intimidation, or punishment, with resulting physical harm, pain, or mental anguish. Abuse also includes the deprivation by an individual, including a caretaker, of goods or services that are necessary to attain or maintain the physical, mental, and psychosocial well-being of the resident. Instances of abuse of all residents, irrespective of any mental or physical condition, cause physical harm, pain, or mental anguish. It includes verbal abuse, sexual abuse, physical abuse, mental abuse, including abuse facilitated or enabled through the use of technology, such as posting inappropriate pictures of residents on social media. Neglect is defined as the failure of the facility, its employees, or service providers to provide goods and services to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. Now, there were actual deficiencies cited of the ICF and IID levels, as well as the assisted living levels. Under ICF IID, there was W154 had 3 citations. This is the requirement that a facility must have evidence that all alleged violations are thoroughly investigated. And then it outlines for you what the thorough investigation must include at a minimum. And that is the collection of all interviews, statements, physical evidence, and any pertinent pictures or diagrams, review of all information related to the allegation, resolution of any discrepancies, summary of the conclusions, and recommendations for action, both to safeguard all clients during the investigation and after completion of the report. There were also 3 citations at W155, which is the requirement that the facility must prevent further potential abuse while the investigation is in process. In assisted living, there were 3 citations for the requirement that residents have the right to be free of mental and physical abuse and chemical and physical restraints, and also 3 citations for the requirement where a covered provider may not allow a covered individual who has been determined to be not eligible for direct patient access to be engaged in a position with direct patient access. So best practices: have a policy to address all elements of abuse, including resident sexual expression. This is the up and coming thing I'm telling you from surveyors. Sexual expression is the new focus under abuse. It has been determined by certain experts that a single assessment may not be the best answer to determining if a resident has the ability to make decisions related to sexual expression. So sexual expression involving residents with cognitive impairment or impaired judgment is something that's got to be looked at very closely. And I've given you some information here. There are 4 pieces of information about how you would want to look at residents with cognitive impairment or impaired judgment when it comes to their ability to express themselves sexually. There is also the abuse critical element pathway, number 20059. This is a lengthy pathway. Again, it has 12 pages, lots of things that surveyors are going to be looking for. I would highly recommend, no matter what level of care you're in, that you review this and use it within your QAPI process, within your facility, to see that you are meeting all of the requirements to protect your residents. So lots and lots of helpful information and questions are asked here. If you are not familiar with it, there are 2 exhibits that CMS released called Exhibit 358 and 359, and I've given you the link to those here on this page, and they look like this. Exhibit 358 is a sample form that CMS has given us for reporting any incidents that must be reported to CMS or OIG, the Office of Inspector General, or your state survey agency. So it gives you an explanation of all the things that must be reported, and then it gives you a form that you can use to do that initial report. It's not required, but even if you don't want to use the form, you might find it very beneficial to use this as your guide to make sure that you include everything they're looking for in your initial report. So you can see it goes on. Let me backtrack for just a minute, and I'm going to run over you guys just a few minutes to get through this, but I think it's very important. It goes through the facility information, the allegation type, the information about when the facility became aware of it, the alleged victims, the alleged perpetrators, the allegation details, etc. So you want to make sure that you're including all of that. Then it gives you a section where you can write out in narrative the specific information. Then you can include the witnesses, the notification of law enforcement if it meets the definition, and the notification of other agencies such as Adult Protective Services, whoever it is that's responsible for that within your state. Now, Exhibit 359 is the follow-up investigation report, or the 5-day report that you use to tell them what your investigation revealed and what your conclusions are. Again, it's not required, but I highly recommend you use this to guide you through preparing your final report so that you will include everything, again, that they're going to be looking for. This will eliminate a lot of questions that will come from them by phone. When you send that information into them, it will have everything that they need. If you use this as your guideline, it will also give the surveyors, if they do come in to do the investigation, a lot of the information that they will need, including, as you can see here, the conclusion and the corrective actions that you took in response to your investigation. And then you can see there's a place for the person that did the investigation and the person that submitted it to sign as well. And finally, I want to leave you with a tool that we developed. It's a checklist for abuse investigation. So this walks you through everything that must be done whenever there is an allegation of abuse to help you make sure that you've done everything that's required. Again, no matter what level of care you're in, you might find this a helpful checklist that you can use and fill out to make sure that you're doing everything required when it comes to abuse investigations to avoid a deficiency when it comes to abuse. I've given you the resources that I've utilized throughout today's presentation, and I've also given you, as you've seen, the links to a lot of the forms and information on the direct slide. I know I've run over just a few minutes, but this was a lot of information to cover, so I wanted to make sure I was able to do it in as detailed as I could. I'm going to see if Allie has any questions for us now, and I want to let you know that if you don't have any questions right now, but if after you've thought about it or gone through the information, you have any in the future, do not hesitate to reach out to me by email. UHCA knows how to get a hold of me. If you want to forward it to them, and they can forward it to me, and I will definitely get back to you as quickly as I can with answers to any of your questions. So Allie, do we have any questions at this time?
No, we do not. Not unless anyone wants to put anything in the chat real quick or want to unmute yourself to ask Janine a question. We'll give you just a moment to do that.
And while we're doing that, I want to thank you guys so much for inviting me and including me in this training for you. I hope it's brought to light a lot of information that you will find helpful to you as you're putting these things in practice in your facilities. As I said, if you think of any additional questions, or if you think of anything tool-wise or form-wise that might be helpful to you related to these or any other deficient practices under the F-tag, please don't hesitate to reach out to me.
All right, well, I don't see any immediate questions, so thank you so much, Janine. We really appreciate your time today and your very thorough review of a lot of pressing issues going on in our state and in our industry. And like she said, if anyone would like to contact her, just let us know. We'd be happy to get you in contact and get your questions answered. And we hope everyone has a great day. And thank you so much for joining us.
Thank you, everybody.